Coronavirus, COVID-19, definition coronavirus disease 2019, COVID-19, also known as the coronavirus, or COVID, is a contagious disease caused by severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. The first known case was identified in Wuhan, China, in December 2019. The disease has since spread worldwide, leading to an ongoing pandemic. Signs and symptoms. Symptoms of COVID-19 are variable, ranging from mild symptoms to severe illness. Common symptoms include headache, loss of smell and taste, nasal congestion and runny nose, cough, muscle pain, sore throat, fever, diarrhea, and breathing difficulties. People with the same infection may have different symptoms, and their symptoms may change over time. 3 common clusters of symptoms have been identified. 1. Respiratory symptom cluster with cough, sputum, shortness of breath, and fever. A musculoskeletal symptom cluster with muscle and joint pain, headache, and fatigue. A cluster of digestive symptoms with abdominal pain, vomiting, and diarrhea in people without prior ear, nose, and throat disorders. Loss of taste combined with loss of smell is associated with COVID-19. Of people who show symptoms, 81% develop only mild to moderate symptoms, up to mild pneumonia, while 14% develop severe symptoms, dyspnea, hypoxia, or more than 50% lung involvement on imaging, and 5% of patients suffer critical symptoms, respiratory failure, shock, or multi-organ dysfunction. At least a third of the people who are infected with the virus do not develop noticeable symptoms at any point in time. These asymptomatic carriers tend not to get tested and can spread the disease. Other infected people will develop symptoms later, called presymptomatic, or have very mild symptoms and can also spread the virus, as is common with infections. There is a delay between the moment a person first becomes infected and the appearance of the first symptoms. The median delay for COVID-19 is 4 to 5 days. Most symptomatic people experience symptoms within 2 to 7 days after exposure, and almost all will experience at least one symptom within 12 days. Most people recover from the acute phase of the disease. However, some people continue to experience a range of effects for months after recovery, named long COVID, and damage to organs has been observed. Multi-year studies are underway to further investigate the long-term effects of the disease. Causes. COVID-19 is caused by infection with the severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, virus strain. Transmission. Main article. Transmission of COVID-19. Transmission of COVID-19 virology. Main article. Severe acute respiratory syndrome coronavirus 2. Illustration of SARS-CoV variant. Severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, is a novel severe acute respiratory syndrome coronavirus. It was first isolated from 3 people with pneumonia connected to the cluster of acute respiratory illness cases in Wuhan. All structural features of the novel SARS-CoV-2 virus particle occur in related coronaviruses in nature outside the human body. The virus is destroyed by household soap, which bursts its protective bubble. SARS-CoV-2 is closely related to the original SARS-CoV. It is thought to have an animal, zoonotic, origin. Genetic analysis has revealed that the coronavirus genetically clusters with the genus beta coronavirus, in subgenus Sabcavirus, lineage P, together with 2 bat-derived strains. It is 96% identical at the whole genome level to other bat coronavirus samples, bat-CoV rat13. The structural proteins of SARS-CoV-2 include membrane glycoprotein, M, envelope protein, E, nucleocapsid protein, N, and the spike protein, S. The M protein of SARS-CoV-2 is about 98% similar to the M protein of bat SARS-CoV, maintains around 98% homology with pangolin SARS-CoV, and has 90% homology with the M protein of SARS-CoV, whereas the similarity is only around 38% with the M protein of MERS-CoV. The structure of the M protein resembles the sugar transporter semi-sweet. SARS-CoV-2 variants. Main article. Variants of SARS-CoV-2. The many thousands of SARS-CoV-2 variants are grouped into either clades or lineages. 63-64, no standard nomenclature exists. Next strain divides the variants into 5 clades, 19A, 19B, 20A, 20B, and 20C. while GS divides them into 7, L, O, V, S, G, GH, and GR. The Pango tool groups variants into lineages, with many circulating lineages being classed under the B.1 lineage. Several notable variants of SARS-CoV-2 emerged in late 2020. Citation needed. Cluster 5 emerged among minks and mink farmers in Denmark. Citation needed. After strict quarantines and a mink euthanasia campaign, it is believed to have been eradicated. Medical citation needed. As of January 2021, 3 newer variants of SARS-CoV-2 are spreading among global populations, including the UK variant, referred to as B.1.1.7, first found in London and Kent, a variant discovered in South Africa, referred to as B.1.351, and a variant discovered in Brazil, referred to as P.1. Using whole genome sequencing, epidemiology and modeling suggest the UK variant VU200 and 2012-01, the first variant under investigation in December 2020, in the B.1.1.7 lineage transmits more easily than other strains. Pathophysiology. COVID-19 pathogenesis. COVID-19 can affect the upper respiratory tract, sinuses, nose, and throat, and the lower respiratory tract, windpipe and lungs. The lungs are the organs most affected by COVID-19 because the virus accesses host cells via the receptor for the enzyme angiotensin-converting enzyme 2, ACE2, which is most abundant on the surface of type 2 alveolar cells of the lungs. The virus uses a special surface glycoprotein called a spike, peplomer, to connect to the ACE2 receptor and enter the host cell. Whether SARS-CoV-2 is able to invade the nervous system remains unknown. However, it is clear that many people with COVID-19 exhibit neurological or mental health issues. The virus is not detected in the CNS of the majority of COVID-19 people with neurological issues. However, SARS-CoV-2 has been detected at low levels in the brains of those who have died from COVID-19, but these results need to be confirmed. Loss of smell results from infection of the support cells of the olfactory epithelium, with subsequent damage to the olfactory neurons. SARS-CoV-2 could cause respiratory failure through affecting the brain stem, as other coronaviruses have been found to invade the CNS. While virus has been detected in cerebrospinal fluid of autopsies, the exact mechanism by which it invades the CNS remains unclear and may first involve invasion of peripheral nerves given the low levels of ACE2 in the brain. The virus may also enter the bloodstream from the lungs and cross the blood-brain barrier to gain access to the CNS, possibly within an infected white blood cell. Tropism and multiple organ injuries in SARS-CoV-2 infection. The virus also affects gastrointestinal organs, as ACE2 is abundantly expressed in the glandular cells of gastric, duodenal and rectal epithelium, as well as endothelial cells and enterocytes of the small intestine. The virus can cause acute myocardial injury and chronic damage to the cardiovascular system. An acute cardiac injury was found in 12% of infected people admitted to the hospital in Wuhan, China, and is more frequent in severe disease. Rates of cardiovascular symptoms are high, owing to the systemic inflammatory response and immune system disorders during disease progression, but acute myocardial injuries may also be related to ACE2 receptors in the heart. ACE2 receptors are highly expressed in the heart and are involved in heart function. A high incidence of thrombosis and venous thromboembolism have been found. People transferred to intensive care unit, ICU, with COVID-19 infections, and may be related to poor prognosis. Blood vessel dysfunction and clot formation, as suggested by high D-dimer levels caused by blood clots, are thought to play a significant role in mortality. Incidences of clots leading to pulmonary embolisms and ischemic events within the brain have been noted as complications leading to death in people infected with SARS-CoV-2. Infection appears to set off a chain of vasoconstrictive responses within the body. Constriction of blood vessels within the pulmonary circulation has also been posited as a mechanism in which oxygenation decreases alongside the presentation of viral pneumonia. Furthermore, microvascular blood vessel damage has been reported in a small number of tissue samples of the brains, without detected SARS-CoV-2, and the olfactory bulbs from those who have died from COVID-19. Another common cause of death is Complications related to the kidneys. Early reports show that up to 30% of hospitalized patients both in China and in New York have experienced some injury to their kidneys, including some persons with no previous kidney problems. Autopsies of people who died of COVID-19 have found diffuse alveolar damage and lymphocyte-containing inflammatory infiltrates within the lung. Immunopathology. Key components of the adaptive immune response to SARS-CoV-2. Although SARS-CoV-2 has a tropism for ACE2 expressing epithelial cells of the respiratory tract, people with severe COVID-19 have symptoms of systemic hyperinflammation. Clinical laboratory findings of elevated IL-2, IL-7, IL-6, granulocyte macrophage colony stimulating factor, GM-CSF, interferon gamma-induced protein 10, IP10, monocyte, chemoattractant protein 1, MCP1, macrophage inflammatory protein 1 alpha, MIP1 alpha, and tumor necrosis factor, TNF, indicative of cytokine release syndrome, CRS, suggest an underlying immunopathology. Additionally, people with COVID-19 and acute respiratory distress syndrome, ARDS, have classical serum biomarkers of CRS, including elevated C-reactive protein, CRP, lactate dehydrogenase, LDH, D-dimer, and ferritin. Systemic inflammation results in vasodilation, allowing inflammatory lymphocytic and monocytic infiltration of the lung and the heart. In particular, pathogenic GM-CSF secreting T cells were shown to correlate with the recruitment of inflammatory IL-6 secreting monocytes and severe lung pathology in people with COVID-19. Lymphocytic infiltrates have also been reported at autopsy. Diagnosis. Further information. COVID-19 testing. COVID-19 can provisionally be diagnosed on the basis of symptoms and confirmed using reverse transcription polymerase chain reaction, RT-PCR, or other nucleic acid testing of infected secretions. Along with laboratory testing, chest CT scans may be helpful to diagnose COVID-19 in individuals with a high clinical suspicion of infection. Detection of a past infection is possible with serological tests, which detect antibodies produced by the body in response to the infection. Viral testing. Main article: COVID-19 testing demonstration of a nasopharyngeal swab for COVID-19 testing. The standard methods of testing for presence of SARS-CoV-2 are nucleic acid tests, which detects the presence of viral RNA fragments. As these tests detect RNA but not infectious virus, its ability to determine duration of infectivity of patients is limited. The test is typically done on respiratory samples obtained by a nasopharyngeal swab. However, a nasal swab or sputum sample may also be used. Results are generally available within hours. The WHO has published several testing protocols for the disease. Several laboratories and companies have developed serological tests, which detect antibodies produced by the body in response to infection. Several have been evaluated by Public Health England and approved for use in the UK. The University of Oxford SEBM has pointed to mounting evidence that a good proportion of new mild cases and people retesting positives after quarantine or discharge from hospital are not infectious, but are simply clearing harmless virus particles which their immune system has efficiently dealt with, and have called for an international effort to standardize and periodically calibrate testing. On the 7th of September, the UK government issued guidance for procedures to be implemented in laboratories to provide assurance of positive SARS-CoV-2 RNA results during periods of low prevalence, when there is a reduction in the predictive value of positive test results. Imaging. A CT scan of a person with COVID-19 shows lesions, bright regions, in the lungs. CT scan of rapid progression stage of COVID-19. Chest X-ray showing COVID-19 pneumonia. Chest CT scans may be helpful to diagnose COVID-19 in individuals with a high clinical suspicion of infection but are not recommended for routine screening. Bilateral multilobar ground glass opacities with a peripheral, asymmetric, and posterior distribution are common in early infection. Subpleural dominance, crazy paving, lobular septal thickening with variable alveolar filling, and consolidation may appear as the disease progresses. Characteristic imaging features on chest radiographs and computed tomography, CT, of people who are symptomatic include asymmetric peripheral ground glass opacities without pleural effusions, Many groups have created COVID-19 datasets that include imagery such as the Italian Radiological Society, which has compiled an international online database of imaging findings for confirmed cases. Due to overlap with other infections such as adenovirus, imaging without confirmation by RT-PCR is of limited specificity in identifying COVID-19. A large study in China compared chest CT results to PCR and demonstrated that though imaging is less specific for the infection, it is faster and more sensitive. 102. Coding. In late 2019, the WHO assigned emergency ICD-10 disease codes U07.1 for deaths from lab-confirmed SARS-CoV-2 infection and U07.2 for deaths from clinically or epidemiologically diagnosed COVID-19 without lab-confirmed SARS-CoV-2 infection. Pathology. The main pathological findings at autopsy are macroscopy, pericarditis, lung consolidation and pulmonary edema. 90. Lung findings: O-serous exudation, minor fibrin exudation or pulmonary edema, pneumocyte hyperplasia, large atypical pneumocytes, interstitial inflammation with lymphocytic infiltration and multinucleated giant cell formation or diffuse alveolar damage, DAD, with diffuse alveolar exudates. DAD is the cause of acute respiratory distress syndrome, ARDS, and severe hypoxemia. O. Organization of exudates in alveolar cavities and pulmonary interstitial fibrosis or plasmacytosis in bile, blood and vessels, disseminated intravascular coagulation, DIC, leukoerythroblastic reaction, endothelitis hemophagocytosis, heart, cardiac muscle cell necrosis, liver, microvesicular steatosis, nose, shedding of olfactory epithelium, brain, infarction, kidneys, acute tubular damage, spleen, white pulp depletion. Prevention. Further information: COVID-19 vaccine, workplace hazard controls for COVID-19, pandemic prevention, non-pharmaceutical intervention, preparations prior to COVID-19, COVID-19 surveillance, and COVID-19 apps without pandemic containment measures, such as social distancing, vaccination, and face masks. Pathogens can spread exponentially. This graphic shows how early adoption of containment measures tends to protect wider swaths of the population. Preventive measures to reduce the chances of infection include getting vaccinated, staying at home, wearing a mask in public, avoiding crowded places, keeping distance from others, ventilating indoor spaces, managing potential exposure durations, washing hands with soap and water often and for at least 20 seconds, practicing good respiratory hygiene, and avoiding touching the eyes, nose, or mouth with unwashed hands. Those diagnosed with COVID-19 or who believe they may be infected are advised by the CDC to stay home except to get medical care. Call ahead before visiting a healthcare provider. Wear a face mask before entering the healthcare provider's office and when in any room or vehicle with another person. Cover coughs and sneezes with a tissue. Regularly wash hands with soap and water and avoid sharing personal household items. The first COVID-19 vaccine was granted regulatory approval on the 2nd of December by the UK medicines regulator MHRA. It was evaluated for emergency use authorization (UR) status by the US FDA and in several other countries. Initially, the US National Institutes of Health guidelines do not recommend any medication for prevention of COVID-19 before or after exposure to the SARS-CoV-2 virus, outside the setting of a clinical trial. Without a vaccine, other prophylactic measures, or effective treatments, a key part of managing COVID-19 is trying to decrease and delay the epidemic peak, known as flattening the curve. This is done by slowing the infection rate to decrease the risk of health services being overwhelmed, allowing for better treatment of active cases, and delaying additional cases until effective treatments or a vaccine become available. Vaccine. Main article: COVID-19 vaccine. Different vaccine candidate types in development for SARS-CoV-2. See also, list of COVID-19 vaccine authorizations. A COVID-19 vaccine is a vaccine intended to provide acquired immunity against severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, the virus causing coronavirus disease 2019, COVID-19. Prior to the COVID-19 pandemic, There was an established body of knowledge about the structure and function of coronaviruses causing diseases like severe acute respiratory syndrome, SARS, and Middle East respiratory syndrome, MERS, which enabled accelerated development of various vaccine technologies during early 2020. On the 10th of January 2020, the SARS-CoV-2 genetic sequence data was shared through GIST, and by the 19th of March, the global pharmaceutical industry announced a major commitment to address COVID-19. In phase 3 trials, several COVID-19 vaccines have demonstrated efficacy as high as 95% in preventing symptomatic COVID-19 infections. As of April 2021, 15 vaccines are authorized by at least one national regulatory authority for public use: 2 RNA vaccines, Pfizer-BioNTech and Moderna, 6 conventional inactivated vaccines, BidCoV, CoronaVac, Covaxin, WibCoV, Covivac and Casvac, 5 viral vector vaccines, Sputnik Light, Sputnik V, Oxford AstraZeneca, Convidia, and Johnson & Johnson, and 2 protein subunit vaccines, Ipivac Corona and RBD Dimer. Failed verification. In total, as of March 2021, 308 vaccine candidates are in various stages of development, with 73 in clinical research, including 24 in phase I trials, 33 in phase I-II trials, and 16 in phase 3 development. Many countries have implemented phased distribution plans that prioritize those at highest risk of complications, such as the elderly, and those at high risk of exposure and transmission, such as healthcare workers. Single-dose interim use is under consideration in order to extend vaccination to as many people as possible until vaccine availability improves. As of the 16th of May 2021, 1.45 billion doses of COVID-19 vaccine have been administered worldwide, based on official reports from national health agencies. AstraZeneca anticipates producing 3 billion doses in 2021, Pfizer-BioNTech 1.3 billion doses, and Sputnik V, Sinopharm, Sinovac, and Johnson & Johnson 1 billion doses each. Moderna targets producing 600 million doses and Convidia 500 million doses in 2021. By December 2020, more than 10 billion vaccine doses had been pre-ordered by countries, with about half of the doses purchased by high-income countries comprising 14% of the world's population. Face masks and respiratory hygiene. Main article: face masks during the COVID-19 pandemic. Masks with an exhalation valve. The valves are a weak point that can transmit the viruses outwards. The WHO and the US CDC recommend individuals wear non-medical face coverings in public settings where there is an increased risk of transmission and where social distancing measures are difficult to maintain. This recommendation is meant to reduce the spread of the disease by asymptomatic and pre-symptomatic individuals and is complementary to established preventive measures such as social distancing. Face coverings limit the volume and travel distance of expiratory droplets dispersed when talking, breathing, and coughing. A face covering, without vents or holes, will also filter out particles containing the virus from inhaled and exhaled air, reducing the chances of infection. But, if the mask includes an exhalation valve, a wearer that is infected, maybe without having noticed that, and asymptomatic, would transmit the virus outwards through it, despite any certification they can have. So the masks with exhalation valve are not for the infected wearers, and are not reliable to stop the pandemic in a large scale. Many countries and local jurisdictions encourage or mandate the use of face masks or cloth face coverings by members of the public to limit the spread of the virus. Masks are also strongly recommended for those who may have been infected and those taking care of someone who may have the disease. When not wearing a mask, the CDC recommends covering the mouth and nose with a tissue when coughing or sneezing and recommends using the inside of the elbow if no tissue is available. Proper hand hygiene after any cough or sneeze is encouraged. Healthcare professionals interacting directly with people who have COVID-19 are advised to use respirators at least as protective as NIOSH certified N95 or equivalent, in addition to other personal protective equipment. Avoiding crowded indoor spaces and ventilation. Crowded indoor spaces should be avoided. When indoors, increasing the rate of air change, Decreasing recirculation of air and increasing the use of outdoor air can reduce transmission. The WHO recommends ventilation and air filtration in public spaces to help clear out infectious aerosols. Exhaled, respiratory particles can build up within enclosed spaces with inadequate ventilation. The risk of COVID-19 infection increases especially in spaces where people engage in physical exertion or raise their voice, for example, exercising, shouting, singing, as this increases exhalation of respiratory droplets. Prolonged exposure to these conditions, typically more than 15 minutes, leads to higher risk of infection. Hand washing and hygiene. Main article: hand washing. Thorough hand hygiene after any cough or sneeze is required. The WHO also recommends that individuals wash hands often with soap and water for at least 20 seconds, especially after going to the toilet or when hands are visibly dirty, before eating and after blowing one's nose. When soap and water are not available, the CDC recommends using an alcohol-based hand sanitizer with at least 60% alcohol. For areas where commercial hand sanitizers are not readily available, the WHO provides 2 formulations for local production. In these formulations, the antimicrobial activity arises from ethanol or isopropanol. Hydrogen peroxide is used to help eliminate bacterial spores in the alcohol. It is not an active substance for hand antisepsis. Glycerol is added as a humectant. Social distancing. Main article: social distancing measures related to the COVID-19 pandemic. Social distancing, also known as physical distancing, includes infection control actions intended to slow the spread of the disease by minimizing close contact between individuals. Methods include quarantines, travel restrictions, and the closing of schools, workplaces, stadiums, theaters, or shopping centers. Individuals may apply social distancing methods by staying at home, limiting travel, avoiding crowded areas, using no-contact greetings, and physically distancing themselves from others. Many governments are now mandating or recommending social distancing in regions affected by the outbreak. Outbreaks have occurred in prisons due to crowding and an inability to enforce adequate social distancing. In the United States, the prisoner population is aging and many of them are at high risk for poor outcomes from COVID-19 due to high rates of coexisting heart and lung disease, and poor access to high-quality healthcare. Surface cleaning. After being expelled from the body, coronaviruses can survive on surfaces for hours to days. If a person touches the dirty surface, they may deposit the virus at the eyes, nose, or mouth where it can enter the body and cause infection. Evidence indicates that contact with infected surfaces is not the main driver of COVID-19, leading to recommendations for optimized disinfection procedures to avoid issues such as the increase of antimicrobial resistance through the use of inappropriate cleaning products and processes. Deep cleaning and other surface sanitation has been criticized as hygiene theater, giving a false sense of security against something primarily spread through the air. The amount of time that the virus can survive depends significantly on the type of surface, the temperature, and the humidity. Coronaviruses die very quickly when exposed to the UV light in sunlight. Like other enveloped viruses, SARS-CoV-2 survives longest when the temperature is at room temperature or lower, and when the relative humidity is low, less than 50%. On many surfaces, including as glass, some types of plastic, stainless steel, and skin, the virus can remain infective for several days indoors at room temperature, or even about a week under ideal conditions. On some surfaces, including cotton, fabric and copper, the virus usually dies after a few hours. As a rule of thumb, the virus dies faster on porous surfaces than on non-porous surfaces. However, this rule is not absolute, and of the many surfaces tested, 2 with the longest survival times are N95 respirator masks and surgical masks, both of which are considered porous surfaces. The CDC says that in most situations, cleaning surfaces with soap or detergent, not disinfecting, is enough to reduce risk of transmission. The CDC recommends that if a COVID-19 case is suspected or confirmed at a facility such as an office or daycare, all areas such as offices, bathrooms, common areas, shared electronic equipment like tablets, touch screens, keyboards, remote controls, and ATM machines used by the ill persons should be disinfected. Surfaces may be decontaminated with 62 to 71% ethanol, 50 to 100% isopropanol, 0.1% sodium hypochlorite, 0.5% hydrogen peroxide, and 0.2 to 7.5% povidone. Other solutions, such as benzalkonium chloride and chlorhexidine gluconate, are less effective. Ultraviolet germicidal irradiation may also be used. A datasheet comprising the authorized substances to disinfection in the food industry, including suspension or surface-tested, kind of surface, use dilution, disinfectant and inoculum volumes, can be seen in the supplementary material of self-isolation. Self-isolation at home has been recommended for those diagnosed with COVID-19 and those who suspect they have been infected. Health agencies have issued detailed instructions for proper self-isolation. Many governments have mandated or recommended self-quarantine for entire populations. The strongest self-quarantine instructions have been issued to those in high-risk groups, those who may have been exposed to someone with COVID-19 and those who have recently traveled to a country or region with the widespread transmission have been advised to self-quarantine for 14 days from the time of last possible exposure. Citation needed. Healthy diet and lifestyle. The Harvard T.H. Chan School of Public Health recommends a healthy diet, being physically active, managing psychological stress, and getting enough sleep. There is no good evidence that vitamin D status has any relationship with COVID-19 health outcomes. Treatment. Main article, Treatment and Management of COVID-19 and Overview of COVID-19 Therapeutics and Drug